this made her to develop a passion for teaching very early in life. Her favorite introduction is a child of two teachers. She was brought up in a simple home with a lot of moral values: honesty, discipline, hard work, generosity, and simplicity. This kind of upbringing made her the honest, disciplined, straightforward person she has remained till date. She has won several awards. I think I must say she has participated in many conferences, both local and international. She is a member of many medical associations, including Nigeria Medical Association, Medical Women Association of Nigeria, Nigeria Society of Neurological Sciences, World Federation of Neurology, World Stroke Organization, American Academy of Neurology, and European Stroke Organization. She has won several awards and is a 2024 recipient of the A.B. Baker Teacher Recognition Award for teaching neurology from the American Academy of Neurology. More importantly, Beta is a born-again Christian, an ardent student of the Holy Bible, a Sunday school teacher who is passionate about studying and obeying the undiluted Word of God. She is also zealous and passionate about women education and empowerment. So please welcome our speaker this evening to deliver the lecture on headache and management. Thank you, madam. You can start.
All right, thank you so much. I'm sorry for I'm not internet savvy. Amen.
All right, you can start your lecture.
I'm not in introduction, and I consider it an honor to be invited by the Society of Study of Pain in Nigeria. It's an honor. Thank you for the invitation. I'm going to be talking about headache and management. And my name is Beta Chioma Eke. I have no conflicts of interest to declare. So we are going to be looking at this content. Next slide. Next slide. Sorry, the person taking the slide. Next slide. All right. Thank you so much. I've said this is my introduction. I have no conflict of interest. Next slide. Next slide. All right. So this is the content. By way of introduction, I love this. I found this picture somewhere and I really like it. Said, I would love to remove my head. That is how maddening headache can be, such that people actually consider if they could just cut off their heads. Next slide. Next slide. All right, so by definition, headache is pain or discomfort between the orbits and the occiput arising from pain-sensitive structures. For it to be called headache, it is between the orbits and the occipits arising from pain-sensitive structures. Headache is the commonest neurological symptom. An estimated 99% of adults have all had headaches in their lives. So if we're like 30 here, at least 27 of us have had headaches in our lives. So we know what it is. And about 90% of individuals have at least one headache per year. Headache is usually a benign symptom. If we don't learn anything now, let's learn that in most cases, but it may also be a manifestation of a serious disease. And approximately 5% of persons with headache have an underlying severe disorder. And that is where attention, my attention as a medical doctor, your attention as a medical doctor should be, spotting the 5% who have a serious disorder. Next slide. Next slide. These are the pain-sensitive structures. Next slide. These are the pain-sensitive structures. Like by definition, we said headache is pain between the orbits and occiput arising from pain-sensitive structures. So mechanisms of headache, for somebody to have a headache, one of these structures is involved. Either the scalp is compressed, distended, torn, the cranial nerve, arteries, either are distended or pulled. All these, something is happening to one of these structures, intracranial or extracranial. Next slide. Next slide. Next slide. This is a classification of headaches, the ones that are diseases. Headaches are classified into part 1, part 2. Part 1 are the primary headaches, where the problem is just a headache. There is no other problem. There is no other cause. While part 2 are the secondary headaches, where something is wrong in the person's body, apart from just the headaches. And the class 3, we did define headache as pain between the orbit and the occipit. But over the years, it is shown that people that have headaches people that have pain on their face, a lot of them also refer to headache. And so those are called the part 3 headaches, cranial neuralgias and facial pain. So the part 1 headaches, one is migraine. Time and again, when people have a severe headache, they just call it migraine. No, every headache is not migraine. Migraine is a well-defined entity that has clinical features. People just say, I have migraine, I have migraine. No, by the end of the day, you have known what migraine is. So there are types of migraine reclassified, migraine with aura, the classical migraine without aura, the common migraine and others. The tension type headache, we're also going to look at it. That's a common one most of us have had. Trigeminal autonomic cephalgias, and then others. Some people just have an idiopathic stabbing headache. And by the time you evaluate, there's actually nothing. Some just have cold stimulus. When they take something cold, ice cream, they start having headache. And you evaluate nothing. Some people just have headache with cough, and you evaluate nothing. And then coital headaches, which may be no cause for alarm, or which may be a harbinger of a serious illness. Next slide. Next slide. The secondary headaches, part 2, the secondary headaches. Next slide, the secondary headaches. These are the headaches where there is a disease somewhere in the body. Next slide. These are headaches where there is a disease somewhere in the body. Number 1 on that will be the vascular headaches. These vascular headaches, brain hemorrhage, subarachnoid, intracerebral hemorrhage, giant cell arthritis, unruptured aneurysms, venous thrombosis, everything in this class, they are all killers. All of them are severe diseases that could kill. And then the non-vascular CNS diseases like meningitis, where be it bacterial, tuberculosis, fungal, parasitic, whatever, encephalitis, and then changes in CSF. If you have ever had a lumbar puncture, or you had surgery and had spinal anesthesia, some of the spinal headache can be maddening. It's because the CSF is too low. And at times, it gets so bad that part of the treatment is actually to get a blood patch. And, we call it blood patch and actually fill up that gap. It can be maddening. And then at times, the CSF is so high. And some of the treatment is serial lumbar puncture to reduce that pressure. Sinus headache, eye conditions like glaucoma can cause maddening headache. Even just not having your correct prescription and you're straining to read can cause maddening headaches. The number 3 are the non-cranial infections. We're all Nigerians, so most of us have malaria. So we will identify with the fact, malaria or bacterial infections, be it chest infection or UTI or enteric fever, all of them cause headache, viral infections. Then substance use and abuse. Substance use, be it the abuse, the withdrawal, or the overdosage, which can kill. So these are some of the common causes of secondary headaches. Next slide. Next slide. Other causes of secondary headaches include intracerebral pathologies like brain tumors, cysts, psychiatric illnesses. Time and again, people come with me, headache. By the time I finish evaluating, I have to refer to the psychiatrist because they're either dealing with depression and anxiety disorder, panic attack, all those cause headaches. And then some other causes, metabolic, homeostatic, and of course, we can't do without head trauma. Some people come headache with, we see it every day, Okada accident, keke accident, people fall from tree, people fall from uncompleted building, all those small head injuries whether minor or major head injuries are a very important cause of headaches. Next slide. Next slide. These are the cranial neuralgias and facial pains. These are the cranial neuralgias and facial pains. We won't talk much about them. The trigeminal neuralgia, just the trigeminal glossopharyngeal, Ramsay-Hunt syndrome, all these cause headaches. Ramsay-Hunt is actually from the 7th nerve, but it's a viral infection, herpes virus. For those who follow music, it was a huge thing that Justin Bieber had Ramsay-Hunt syndrome. It was all over the place. Yes, it can cause some maddening headaches. So how do you evaluate a headache? Because the emphasis on this is we're going to look at when you know, how do you evaluate a headache? When do you know that this person needs attention? When do you know that the owner of this head needs attention? So evaluation for all the medical doctors here, we know this is standard practice. One of the founding fathers of medicine, Sir William also said, listen to the patient. Why often he's telling you the diagnosis? You can't run away from history taking. Every headache is not the same. Next slide. Next slide. Take attention. Do widespread investigations before you know what is causing this headache. Next slide of headache. All right. I said, okay. So I said, listen to the patient. Quite often he's telling the diagnosis. Next slide. So we're going to take a history. Every medical doctor here knows when you're taking a history of pain, we have a mnemonic, Socrates. What is the site? Where is the site of the headache? Is it frontal? It's occipital. Frontal headaches usually refer to either the eyes or paranasal sinuses. Somebody has headache, it's in front, it's in front. Look again at the person's eyes, look at the prescription, look at whether the eyes are red or one thing or another. Onset of headaches. And then by the time the person has
Can you unmute yourself, Dr. Eke? You are currently muted.
mute it. Why can't I mute myself now? What's the problem, Siri Wahala?
We can hear you now.
Can you hear me now?
Yes.
All right, thank you so much. Having evaluated, we're looking at benign causes of headache. If you don't learn anything today, learn this. As much as 90% of headaches are benign, there's no cause for alarm. As much as 90% of headaches are benign, there is no cause for alarm. Hunger causes headache, anger, noise, music. Personally, when I go for an occasion, I make sure I keep my distance from the musicians. In between the music, the musical equipment, the loudspeakers, amplifiers, I'll have headache. So noise, music, poor or inadequate or insufficient sleep, just sleepless nights. Time and again, I have nursing mothers, they will come to me with maddening headaches. And by the time I finish evaluating, really now the very severe causes, I tell them it's just a sleepless night, just being awake all through the night to nurse your baby. And I tell them, I see the elders have it right. In our culture, when you have a new baby, either your mother, your mother-in-law, your elder sister, your auntie, a matured woman who knows what it takes is supposed to be around to help you. Once the lady is all alone, all through the night, nursing the baby, changing diapers, the headache can be maddening, and it's just insufficient sleep. Exertion, fatigue, psychology or emotional stress. I've seen it cause so much maddening headaches. I do remember one of my favorite stories. The patient was a 73-year-old woman. She's Caribbean, but married to a Nigerian. So it was a 50-year-old marriage as at the time I saw her. And in their 50 years of marriage, they've lived in Nigeria for only 2-3 years. For more than 45 years or in the UK. So where she comes from in the Caribbean, hurricane is an issue. You're not in a hurry to build a house because hurricane will bring you down in the next 8 months or 1 year. And having lived in the UK, they pay mortgage for years and years and years, and you still don't have a house. But back home in Nigeria, either your father gives you a land or you buy a piece of land. In 2-3 years, you've already built a house. And 5 years later, you still have a house. 10 years later, 15 years later. And so one day, Nigerian government became hurricane. They wanted to expand the road and they pulled down the house. She started having maddening headaches in the UK. They did 6 MRIs, they didn't see anything. And so when she came to the country, in Nigeria, somebody asked her to see me. And I sat down. By the time I finished evaluating, I said, "Man, there is no problem with your brain. That's why the MRI didn't pick anything. It's the psychological stress from the loss of your home. That's the problem. The despair, the helplessness, their house valued at 50 million. Government said they'll pay 10 million. Of the 10 million, they had not paid her 1 kobo. As they were pulling down the house, the in-laws ran in, carted away, and shared imported furniture from UK. This one carry fridge, this one carries TV, this one carry. So all that, all the pain, the anger, the despair, the helplessness, at 73, when she comes to Nigeria, she will go squatting. So that is, so terrible stress like that can cause headache. I've seen it. Some people, so I need to ask, what is the cause of the headache? Is there any stress, physical stress, crying, alcohol intake and hangover, menstruation? Those of us who are ladies can acknowledge this: menstruation, physical problem. And for the ladies, wearing hats, tying tight scaly, plaiting tight hair, hairband, all those cause headaches. So as much as 90% of headaches, and I see maybe 1 or 2 more things I've not put, are benign. There is no cause for alarm. Just being overworked, just being stressed, just trying to meet a deadline, just being on call 2-3 days, and every day you don't sleep till 4 a.m. All those cause headaches. Next slide. Next slide. Next slide. When then is a headache significant? What are the red flags? When do you know that the owner of this head needs attention? These are the issues. So those are what we're looking for when you evaluate. 1, headaches that disturb sleep. Headache, sleep is supposed to alleviate headache. If you're having headache, take a bath, relax yourself, eat food, lie down and sleep. It handles the anger, the crying, the physical exertion, the emotional stress, the sleeplessness. It handles about 5 or 6 factors. But when somebody can't sleep because he or she is having a headache, or headache wakes up the person from sleep, cluster headache, persons with cluster headache wake up at 2 a.m. with their head inside their hands screaming, or somebody wakes up early in the morning, instead of being refreshed or reinvigorated, he or she is having a headache, I will be bothered. Headache that disturbs sleep. For the ladies, if you wake up having headache in the morning, look at your hair again, loosen it. Maybe you tied your band. Maybe it's your hair net. Look again. But for a guy or a lady who said it's in the morning somewhere, that disturb sleep, start having headache. That's a feature of raised intracranial pressure. I'll be worried. When the person describes that worst headache of my life, I said as much as 98% of us know what a headache is. So somebody says, I've been having a headache, doctor, but this is the worst headache of my life. That's a classical description for people with brain hemorrhage. Meningitis is so severe. Headache with other features. Somebody has headache and has fever. It may just be malaria, but paracetamol won't take care of it. The person needs anti-malaria. Somebody has headache and is losing weight. Somebody has headache and is vomiting. Somebody has headache and has seizures. Somebody has headache and is talking off point. Somebody has headache and can't see clearly. Once there is something else. Headache in anybody. Number 5, headache in some person who already has a medical diagnosis. Somebody who is hypertensive has headache. Please be worried. Is he going into encephalopathy? Is a person about to have a brain hemorrhage? Somebody who has HIV has headaches. You should be worried. Somebody who has asthma, sickle cell disease, diabetes, cancer. Once a person has a medical diagnosis, you should be worried. Headaches worsened by increased intra-abdominal pressure. Somebody has headache, and when he coughs or bends his head or urinates or carries a bucket of water, it's like the head is about to fall off. That's also another feature of raised intracranial pressure. Headache onset in anyone who is more than 55 years old. So when your 60-year-old auntie, when your 75-year-old mother or father has a headache, you should be worried. Something is wrong somewhere. And then when I examine and I see any neurological deficit, I'll also be worried. These are the red flags. May I say it again, that as much as 90% of headaches are benign, there is no cause for alarm. But then when these are red flags that are bingers, that something is wrong somewhere and you shouldn't take it sitting. And so you take time. I remember once I was a 20-something-year-old girl. My house officer clerk was presenting, and I thought that it was a benign headache until she said something. She said the girl had a fall. I said, how did you fall? She said she missed her step and she fell down. I said, no, your head shouldn't touch the ground when you miss your step. As a 20-something-year-old, you should be able to break that fall, hold something, wedge yourself somewhere, tear your dress, sprain your ankle, spoil your shoe, but your head is on the ground. I say she lost consciousness. That's not normal. And I ordered a CT scan, and I was right that something was wrong somewhere. So next slide, we usually examine, well, I don't have so much time because we stay late, but we usually examine. You must do a general examination. Is there fever? Is there jaundice? Is there cyanosis, pallor? All those are habinga, edema, rashes, that something is wrong. Tells you which system. You'd also examine all the systems, and the neurological examination is a person conscious or unconscious, features of meningeal irritation, cranial nerve palsies, paresis, and what have you. Next slide. Investigations. Investigation should depend on the history. If I'm talking to medical doctors today, let's remind ourselves that poverty funds colors a lot of our practice in sub-Saharan Africa, rightly so. We pay for our healthcare, out-of-pocket expenses. So what happens in UK and US does not obtain here. Somebody says, I have a headache in US, they quickly do brain CT scan. Let me remind us that as of today, CT scan is about 85,000 naira. How many of us seated here have 85,000 naira now? So that's the issue. And so we take our time to evaluate and pick out the people who actually need to be investigated. So somebody will say, I have a headache. You say, go and do CT scan. You don't know whether the person has eaten. You don't know whether they have not paid the person's salary. You don't know whether rent has expired and landlord is about to chase him or her out. You don't know whether the woman just found out her husband has a new girlfriend and she's crying every day. So all these may cause headaches. So usually we investigate depending on what we found. We've already made a clinical diagnosis. We know this is meningitis, or it is, or something like it. We know this looks like a brain hemorrhage. We know this looks like a brain tumor. There's already an idea. Please don't order CT scans from the phone. I'm having a headache, oh, my head, oh. You don't know whether the landlord bought a new generator and put it by his bed or her bed. And all through the night, generator, the person will have a headache. So we take time to evaluate. So neuroimaging is not always necessary. I know it looks as though it's not the ultimate. Do a CT scan. Have you done CT scan? Have you done CT scan? You take time to evaluate. Remember, as much as 90% of headaches are benign. Next slide. So management will also depend on what we see. Most benign causes, we just respond to paracetamol and you remove the trigger or whatever it is that you have found is causing the headache. Others we treat accordingly. The example, somebody has the infection. You do antibiotics, treat. Next slide. Some specific headaches demand attention. Next slide. We take time to look at some. These are 3 of the primary headaches that we know. If we look at that slide that they just passed quickly, you see the sides. That's why I put this side. If you're a medical doctor here, look at the sides. Migraine headache is classically unilateral on one side. Occasionally, it may be bilateral, but classically it's one side. Cluster headache is around the eye. They feel as though somebody is trying to screw out one eye, trying to drill out and bore out one eye. And then tension headache, all of us will appreciate that from the back of the head, as though the person is carrying a heavy load, as though there is a tight band. So we'll just quickly look at some of these brief headaches, and then I can round up. Next slide. I won't discuss all the slides because there are many. So migraine, like I said earlier, some people just have headache and they say, I have migraine, my head is migraine. No, migraine has a diagnosis. One, it's a cyclical headache. It's common and often familiar. Migraine starts in childhood. It's a disease of young girls in their late teens and early 20s. So the one time where a 65-year-old man came and said, doctor, I have migraine. In my mind, I say, sir, please, you don't have migraine. Just sit down, let me find out what you have. Because migraine is not a disease of 60-year-old men. It's a disease of 20-year-old girls. So the epidemiology was wrong. There's a family history in 70% of cases. Most girls that have migraine, look again, either their mother or their elder sister also had migraine. I won't go through the theories, but the role of neurotransmitters and currently the calcitonin gene-related peptide has been found to be very important. And there are medications that inhibit it. Very expensive, but they're working wonders. Next slide. I have another long list of migraine precipitants. Any disease that has precipitant is good news. If you can just avoid the precipitant, the trigger, you're 80% home. So this first page is a long list of what they don't eat. You can see it's not all of us. The person who has migraine goes through thiramine-containing foods like cheese, chocolates, maybe too expensive for us now. But if you start from fermented food, I gave a long list. So you know, the person will know the one which one is eating. Fufu, ogi, elubo, kunu, fura, tuwo, oba, iru, ogili. It's a long list. You know, those fermented foods have been known to be precipitants. Overripe fruits, bananas, dried fruits, raisins, avocado pears, caffeine. I love coffee, but I don't have migraine. So those who have migraine, avoid caffeine, artificial sweeteners. And then monosodium glutamate is what is in white maggi. At times I just tell my parents, my patients, once you're eating outside, you don't know what you're eating. It's only when you cooked your food, you know what's inside. So at times I just stop them, cook your own food, don't eat outside. Citrus fruits have been implicated. All the citrus fruits, orange, lime, tangerine, 5 alive with 5 citrus fruits. And then meats with nitrates. Mercifully, poverty has not allowed us to have this one: bacon, corned beef, ham, hot dogs, pepperoni. So you can see that poverty has some of its advantages. We eat other things. We most of us can't afford these are the orders. Hormonal changes like menstruation, there's a period. So we try to control the dysmenorrhea before, we try to control the pain before the menstruation, stress again, excessive or insufficient foods, medications like vasodilators, oral contraceptives, smoking, exposure to bright light. Next slide, you have not turned. Please turn the slide. I've left the food page. I'm on other things now. Fine, please turn next slide. Yes, as other precipitants, it's still a long list. Look at screen, phones. Phones and laptops and TV. Are there some young people listening to me? Do you have some teenagers and some 20-year-olds that can't drop their phones? Phones, always in front of their phone, their laptop, their iPad, watching TVs are triggers for not just migraine headache, but even seizures. Other triggers include strong odors, perfume, skipping their food, lack of exercise, ice cream. Typical symptoms, migraine is throbbing, he's beam on one side, but it's a cyclical headache. On its own, it should abate. Like the patient I saw today, she said she has been having headache since last week and there is migraine. I said, no, sorry, man. You've been having headache for 8 days. That's not in keeping with migraine. Migraine, whether you intervene or not, it's a cyclical headache. Somewhere between 4 to 72 hours, it will stop on its own. Nausea, vomiting, they can't look at the sun. I just put these visual auras. There are some things that people notice before the headaches. Some usually visual flashes of light. Some are seeing zigzag. Some are seeing zebra crossing. Some people can't talk. Some people with dizziness. It's a long list. And once you have all these, anybody who has all this, it actually encourages us because it means you can halt it at that level. You can give a medication so the person doesn't go through the headache, but halt it at that level. Next slide. So the next slide is the International Headache Society for Diagnostic Criteria for Migraine. I leave for the medical doctors when you go home, you can look at it. And then the next slide, I found this picture somewhere and I really love it. It's a cartoon. Next slide. And the person said, if you're typing a status update that says you have migraine, then you clearly don't know what migraine is. So this is what migraine is. It's a young girl. She can't look at the lights. She has to be in a quiet position. She can't look at her phone. She can't type anything. So that it is. Management modalities, number one. Yes, so I was just talking about that picture. I said I found and I like it. This is what migraine looks like, a young girl. Management modalities, avoid, reduce the triggers is very important. So I always give my patients a very long list and say, pick the ones you're doing. One of them is a trigger. One of them is a precipitant. If you can control it, we're 80% home and dry. And then for those, the non-pharmacological therapy, biofeedback, cognitive behavioral therapy, these are the things you need clinical psychologists and all that to do. Most of us don't have them available. But pharmacological medications, ergotamine is very common, cafegots. NSAIDs are also very important, especially when you add metoclopramide to prevent the nausea and vomiting. Very effective treatments, and currently the CGRB inhibitors. I think one pharmaceutical company has brought it in, but it's so expensive. But also, they are dramatic and effective, whoever can afford them. Migraine is a cyclical headache. So the word is not cure. The word is break the cycle. When we have broken the cycle, then we introduce prophylaxis. Next slide. Okay. Next slide. Yes, so when the migraine does not abate, we call that status migrainosus, and then you need to admit the person. So you need to admit the person. So cluster headache is the next headache. I put cluster headache so you can recognize it because it's dramatic. It's also called suicide headache. It's the most painful of all the headaches. It's so painful that sufferers contemplate suicide. Some have succeeded in taking their own lives. The headache is so severe that the person would rather die. So it's also called suicide headache. It occurs in clusters. It occurs in clusters a particular time of the day, in a particular time of the year. So the person may not have headache till around that time of the year, and the person having it every day at a particular time. It's usually nocturnal, wakes the person up by 2 a.m. It's classically, and it's commoner in young men in their 30s. Next slide. It also has some precipitants, some cutaneous injections, some stress, some people's allergies. If you find out what you're allergic to, seasonal changes, especially hot weather, and then alcohol and heavy smokers. So these are, which we know is a disease of young men. They are the ones that take a lot of alcohol and smoke, and it's a trigger. And then watching TV, also sexual activity. These are the risk factors, the disease of young men. And then previous surgery may also or previous trauma may also be a risk factor. The clinical features, I said the pain is intense, it's maddening. Next slide. The pain is intense, it's maddening, strictly unilateral, one side, around the eye. The sufferers will tell you it's as though somebody is taking a borehole and doing everything to remove one eye. And doing everything to remove one eye. It occurs many times. It doesn't last long, 15 minutes, 45 minutes, never more than 3 hours. But it's so intense that in those 15, 45 minutes, 1 hour, the person may actually commit suicide because of how severe it is. And they usually have the eye will be red, pouring with water, lacrimation, and all that. They're usually restless. They are walking all over the place. While the person with migraine is in one quiet, dark place, trying not to make any movement, not to look at the light, not to look at the phone. The person with cluster headache is agitated, restless, crawling, screaming, walking up and down, so restless. Next slide. All right, so this diagnosis for the doctors who want to see is just clinical. Laboratory investigations, and you just want to rule out something. When there's an atypical presentation, you really want to know what else may be happening. Treatments. Treatment is also abortive. Break the cycle, break the symptom, reduce this headache, and then thereafter prophylaxis. One thing that has been known to be dramatic is oxygen. You see a young man holding one side of the head, it's red, screaming, water is pouring. Take him to accident and emergency and put oxygen on his face. It's so dramatic. In 10 minutes, the headache goes, and then you can now place on prophylaxis. Some of which have the calcium channel blockers, some anticonvulsants. I'll soon conclude. Tension type headache is the one all of us have had. It's a recurring headache over and over. Some time ago, a senior colleague came to me who has been a medical doctor for about 40 years. And he said, "Doctor, I've been having this headache ever since." Has it gone off again? Okay, tension type headache. And he said, "I've been having this headache ever since I was in medical school. The headache. And I told him, I said, "Sir, you read medicine with this headache, finished residency, you have been working at a medical doctor for more than 30 years. I said, one thing I know is that there's no cause for alarm. If there was any serious thing, he would have been dead long before now." And he laughed. So that's the kind of thing, tension headache. Most of us have felt it, as though that you're carrying a heavy load, as though there's a heavy band from behind the back of your head to the front, as though somebody has tied something very tight. Usually cause a lot of time from stress, and then most of the things that cause benign headache worsen it: crying, noise, music, poor posture. And people wake up in the morning. Next slide. People wake up in the morning and they feel as though their head is about to drop off. It's usually pressing. They feel as though somebody is trying to press their head, or somebody is tying a very tight band, or that somebody is trying to, give them a heavy load to carry. Next slide. Next slide. It's difficult to move these slides now. Next slide. Next slide. Yes, please. Next slide. Please. Next slide. Okay. Next slide. I'm discussing.
Sorry, can you unmute yourself?
Doc.
All right, I'm too far. How did you reach there? Can you go back a few more slides? Can you go back a few more slides? It went back too quickly as I was screaming next slide and next slide. Because I just want, yes, next slide. Go back again.
Please, my friend.
Yes, giant cell arteritis. I'm done with, yes.
Nice.
So the tension headache, which we have all had, and relaxation, people use one press, the slides to be shared so you can quickly, because we're almost finishing. So the slides you can also quickly Next slide. I must discuss giant cell arteritis because this is a disease. The first three are primary body, but this is the one that is a disease of the body. All right, because it commonly affects the artery in the brain for whatever reason. I don't know why it told temporal artery to be the commonest headache. So it's also temporal artery. It may be abrupt or insidious. This is one headache that you must treat because there's an autoimmune disease of all the vessels in the body. So it affects, at first it may even start with fever, malaise, because the person is actually sick. Fever, malaise, night sweats, weight loss before the headache, fatigue, malaise. And it's classically a disease of senior citizens, people who are more than 50 years. Note that jaw claudication is what? Pathognomonic. Classically, it's worse once they open their mouth to talk or to chew. So it's part, once you see that, you see somebody is more than 50 years, holding one side of the head, my head, I'm tired, I'm having fever, I'm malaise. And then say, ma, when can you open your mouth? When you're talking, is it worse? When you're chewing, is it worse? It's giant cell arteritis until proven otherwise. So I've looked at, I'm trying to round up now. I've looked at the examination features and then clinic, next slide. Next slide. Yes. Look at the clinical features and okay, examination when you examine as a medical doctor and you look at it, investigation, the ESR is usually in the sky. The ESR, then they have anemia, they have a thrombosis. You recall it's an autoimmune disease of blood vessels. And then temporal artery biopsy, I've never done that before, but it's often diagnostic. Next slide. This one you must treat. The treatment is prednisolone, which mercifully is available, is cheap, and the effect is dramatic. One of the women I treated, the next visit, 1 week later, she came with wrapper. She came with one Ankara and said, doctor, you mean I'm still alive? I thought I was going to die with a headache. So it's prednisolone is dramatic. I have a list of complications so you know why it's a dangerous disease and why I had to discuss it. The headache can cause from diplopia to blindness to stroke to gangrene of one limb because we're talking about blood vessels. It's a vasculitis. Every part of the body has blood vessel. So it can pick any blood vessel. And whichever one it picks, the effect can be ridiculous. The pest can be very dangerous. Next slide, you see this, the list of, next slide. Next slide. The next slide, all the complications. Next slide, please. Yes. So this is a list of complications. Ischemic optic neuropathy that can lead to diplopia, lead to blindness, which can be either temporary or permanent, lead to stroke, lead to loss, lead to sudden paralysis because it's a vasculitis. There are blood vessels all over the body, can lead to gangrene if the vessel to one limb is affected. That's why you must treat. In fact, not only do we treat, we maintain them for life on prednisolone because there's a vasculitis. All the blood vessels are inflamed. Whichever one is inflamed, the complications can be disastrous. Last but not the least, let me mention there is something called medication overuse headache. Next slide. medication overuse headache. Next slide. Next slide. Yes, there's an entity called medication overuse headache or rebound headache. People keep consuming frequent medications. I'm having headache. I'm having headache. And so we say they confirm episodic suffering to chronic suffering. From suffering in episodes, it's now chronically this headache won't go. They can't sleep. They can't stand. It can be caused by any of the common analgesics. It's common in people who have migraine or tension headache. They will just wake up in the morning, headache, 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 neck pain, poor sleep. The problem is it causes anxiety, depression, and there's that danger of overdose. So the person can overdose and destroy the kidney, destroy the liver, or even die. That is why it's an entity. In most cases, we withdraw the medication, 100% withdrawal of that medication. And then we use some non-pharmacological, avoid the trigger, lie down, rest, eat good food, drink plenty water, and all that. Relaxation techniques in most cases. All right, thank you so much. In summary, I did say that headache is the commonest neurological complaint. I'm summarizing and rounding up. Next slide. Headache is the commonest neurological complaint. Most of us, 98% of us have had headaches. And as much as 90% are benign. If you didn't learn anything, just try and fix that one in your head, that as much as 90% of headaches are benign. Commonest primary headache is tension headache. We have talked about the red flags, the significance that will tell us that something is happening somewhere. You should sit up as a medical doctor. You should refer to a neurologist. The commonest causes of secondary headaches are sleep infections, between meningitis and malaria and chest infection or typhoid ultimate. In conclusion, next slide. Next slide. Yes, conclusion. I found this cartoon and I love it. Happiness is suddenly realizing that your headache has disappeared. So thank you everybody for listening. I'm sorry about all the hitches with my phone and the meeting. Thank you everybody and thank you for inviting me. Thank you so much.
Thank you so much, Dr. Bataiki. That has been a scintillating and very interesting lecture and very real. I'm sure everybody is able to get to know and get used to this and know those kind of headache. It's really educative indeed. The floor is now open for questions. If you have any question, you can raise up your hand and or you can use the chat box. I want to really appreciate you because I really enjoyed the lecture very much. Though I want to ask a question. Is there, to classify headache, what's your perspective? Is headache a pain or something else? Dr. Eke, are you able to give a perspective on
The
whether
floor
there
is
is
now open.
Yes, are you able to give a perspective on whether headache is purely pain? Oh, she's having network issues. Okay.
Myself, okay.
Yes. Can we distinguish headache as either pain or completely or something that has a component of pain? Did you hear my question?
No, sorry, please. Could you please, yes.
Okay, I was
Could you please
saying
ask again?
that sometimes when we want to classify headache, that can we completely put it as
Okay.
pain or something else bigger than pain?
Headache is pain. It's part and parcel of pain. Whatever else is involved is part and parcel of pain. There's nobody who has a headache that is happy. So it's pain. And the thing is that pain is a protective reflex. It's warning you something is wrong somewhere. You know, people that are told don't have the pain systems working. Example, people like diabetics. If it's not working, the person can put a hand inside the fire. There is no pain to warn you. Remove your hand, it's going to burn you. So pain is protective. Headache is pain. And pain warns you that something is wrong somewhere. Yes.
Thank you very much. Do we have any other question for our presenter this evening? I'm not sure whether you spoke about whether the effect of, I'm sure you probably have talked about it, the effect of hypertension on the headache.
All right. Hypertension is not a common cause of headache. When somebody who has headache, you should be worried as a medical doctor. Something is wrong, some encephalopathy, or he's angry, or somebody or something. So hypertension does not cause headache, but rather headache will increase the blood pressure. Physiologically, bladder, anxiety, worry. So it's the relationship is not hypertension causing headache, except there's something severely going on wrong. But rather, headache will increase the blood pressure because the person is in pain. There's a question on the chat about aneurysm. I think somebody said.
Yes, he said, how does one identify headache from aneurysm?
Headache from aneurysm, one of the very terrible headaches. There is usually one-sided headache. It's throbbing. It's going to disturb sleep. It will not abate on its own. It will not abate on its own. Other things, it may be worsened. It's a bit young. It's a bit common in young girls. Anything that will enlarge vasodilatation, pregnancy prepare room, it may be common. I remember one of my students came there some years ago, and she came and I came, which is very like me, like you heard me say, we must evaluate first. And later on, when she was doing her smartship, I was told she was found dead because I thought it was a brain aneurysm. So it bursts in the night. So the pointer, maddening headache, usually one-sided. There may be seizures. There will be other things like either visual problem or dizziness or problems with hearing. Headache will disturb sleep. The person won't be able to sleep. All the other things, handling all those noise, music and everything, is still not abate. And in most cases, some medications may lessen it or more. So before it was, other students came and said, my drug. For me to be bothered enough to ask a 22-year-old girl to do a contrast-enhanced brain CT scan, I saw about 5 or 6 red flags. You may not, the person who asked that question, you may not generally know exactly what is wrong, but guiding you that something is happening inside this brain. So most likely, apart from the headache, they will also have seizures.
Thank you, Doc.
Somebody asked, has paracetamol been bastardized?
No, okay. Somebody first asked a question. He said, can one take pain reliever such as paracetamol each time a headache happens?
Okay.
And then you have a follow-up question: has the drug paracetamol been bastardized?
Yes, paracetamol is a good medication for those benign headaches, but it will be nice if you can recognize what is causing the headache and avoid it. So you don't enter into medication overuse. You understand? Medication overuse headache. Paracetamol is one of the culprits. Let us also remember that paracetamol overdose causes some liver issues. So yes, it's nice. Everyone has more paracetamol, as long as you don't overdo it. It's supposed to be 2 TDS. By the end of 1-2 days, even the people that wrote it will say, if your headache persists, make sure you see your doctor. So you don't bastardize it. If it's truly a benign headache, in 1-2 days, you should handle it. Like if I just go, let's say at a bed and I was crying, when I come here, I just take 2 tablets of paracetamol. The next day is gone because I've slept. So it's not as I'm going to be taking it for 1 week. Yes.
Thank you. Dr. Namani, please ask a question. He said, where do you classify headaches that disappear after sleep but come back few hours later and become consistent? That is, headaches that are only relieved by sleep.
Well, if it's relieved by sleep, maybe it's telling you that you're under a lot of stress, there's a lot of tension, you overworked, So one of the things that I have seen work is if you're an overworked person, try and take 10-15 minutes within that period. Just put your head on your table or inside your car. That rest can be fantastic. So the person that your headache, sleep relieves it, is telling you it's one of those benign causes in between physical stress, fatigue, overwork, noise, whatever it is. So it's telling you that your body needs rest. So however busy you are, find 10-15 minutes to just put your head on the table, close your eyes, remove your glasses, don't read anything, remove the lights, remove the laptop. If you're busy your bank, those 10-15. So the headache is coming, you're relieved by sleep. Hours later, you're back under the tension, under the stress, under the physical activity, under whatever it is that the sleep handled. That's what I understand.
Thank you very much. I don't think there is any other question. What we need to do is just to appreciate you for this educative lecture. We are so appreciative from the society or for the
all right, thank you so much.
Nigeria. I've moderated myself as the president of the society, Professor Bamidele Oyele, and we are so grateful for all you have done. We thank all the people that came for this or that is attending this webinar. Thank you so much for honoring our invitation. It has been enlightening so much. We know what is migraine. We know that it's a disease of the young girls and what have we. Thank you so much. Thank you for the passion that you have put into this and for the beautiful slides. Thank you, every one of us. And we encourage us, those who are not members of the Society for the Study of Pain, to please take up membership. It's just 10,000 naira, and then enjoy some of our the right benefits. Thank you very much. Thank you, Doc.
You're welcome.
So good night, everybody. Thank you so much. Good night.
Good night.
Good night.
Good night. Good night. Dr. Eke, thank you for coming. Good night.